Dobre Utra. It's a pleasure to be here. I'd like to thank the organizers for putting this wonderful conference together. It's an honor to speak here today. So as we've learned from other talks, there is a strong rationale to combine hyperthermia with other cancer therapies. Hyperthermia can make each of these treatments more effective. As we've learned, it complements radiation in many ways, taking cells that are most resistant to radiation. Those are the type of cells that are typically most sensitive to heat. We also, as we just discussed, increase perfusion, often for a period of days after the hyperthermia. And as we'll talk about, there's also opportunity in regards to inhibition of DNA repair caused by radiation, and likewise with certain chemotherapy drugs, such as commonly used ones, cisplatin, as well as newer agents like PARP inhibitors, as I'll discuss. And then there are intriguing possibilities in regards to immunotherapy, as we heard from my colleague yesterday. So where have we been at this point in prostate cancer and clinical trials? Unfortunately, we don't have phase 3 data in prostate cancer, but we have a range of small studies, including some phase 2 studies that have shown promise. To be frank, one of the challenges here is the heterogeneity of the patient populations and trying to extract meaningful information from these prior studies. Looking at one that I was involved with during my time at the Dana-Farber Cancer Institute at Harvard, we had a phase 2 study with a modest number of patients, 37. But one of the keys here was after the first 4 patients were approved without hormonal therapy, the data from RTOG 8610 became available, establishing hormonal therapy as standard of care. So that was rapidly integrated into the prospective design of the study. And so all our patients were fairly well controlled in terms of the treatment they received being consistent, as well as their presentation. And what we did prospectively was use the historical controls from another RTOG trial, 9202, which included 4 months of hormonal therapy with very similarly staged patients looking for a better than 19% difference in this patient population. The doses going back to the 90s were obviously less than what we use now. So this is a population where we can really see the impact of hyperthermia in terms of the thermal enhancement ratio. So in the end, what we saw was an absolute, not actuarial, but absolute 2-year progression-free survival result of 84% versus the 64% on the RTOG trial. And this was statistically, and I would argue also clinically significant. And as we look back over 7 or 8 years, our patients were still by and large doing very well in comparison to the control group. That was also treatment that was very well tolerated. Looking at even more advanced disease, the group at Northwestern University Hospital in Chicago treated some very advanced prostate cancer patients, either upfront treatment or as second line for local control. And in this paper, you can see they had a number of if I have a pointer here, but you can see at the arrows, a necrotic tumor. The rectum is pushed all the way back here, and after treatment, you can see, the rectum is now no longer. Thank you. Great. The rectum is no longer compressed. There was some bladder invasion, looks much better. Similar situation in this patient. In our own experience at Thomas Jefferson University in Philadelphia, where I now am, we had this patient come from Minnesota, about 2,000 kilometers away, was referred to us. And what you see here is this is a 9-centimeter prostate tumor invading into the bladder and invading into the rectum. Awful situation. And he was referred to us where he has been on long-term androgen deprivation, initially with a very modest response to the androgen deprivation. And subsequently, we treated him with 78 gray plus weekly deep regional hyperthermia. And he has gone on to have a complete response. He's 78 years old. He's playing tennis twice a week. He's enjoying life. So it's very powerful what you can often see with the additive effects of hyperthermia in addition to radiation therapy. So I want to talk about not just where we've been, but where are we going with this treatment. And one of the ways that we can enhance the use of hyperthermia is through improved physical targeting. And one way to accomplish this is with high dose rate brachytherapy. Our Pyrexar BSD system is completely compatible with our Nucleotron HDR system, so that we can use the same catheters for the HDR treatment and swap out the source for the hyperthermia antennas to effectively heat in this well-defined area immediately after treatment. What you see here is a challenging situation where patients have radio recurrent prostate cancer. And this is data from UCSF showing 5-year results with HDR alone, not with hyperthermia. So HDR alone. And they found that this was very well tolerated. There was no serious toxicity with this approach. Subsequently, they looked at some gynecologic and prostate patients combining hyperthermia with HDR, and again found a very acceptable toxicity profile, promising initial results in terms of outcomes. The group at UCSF is not alone in that the researchers in Poland, particularly Dr. Kukiata, have done work in this area. They have done 3 implants, giving 10 gray each time with hyperthermia. Give them a lot of credit, as these glands are typically fibrotic, and then doing 3 implants, I think, is a significant challenge. To help address that, we now have a trial open at Jefferson where we are combining hyperthermia with a single 15 gray fraction of HDR therapy, with the idea that we expect to see a thermal enhancement ratio based on numerous other trials of about 1.5, meaning it is going to be like giving 22.5 gray, but without the risk of added toxicity, noting the most commonly used primary upfront dose with single fraction is 19 gray. So we believe this is a good strategy to minimize toxicity and improve outcomes in these patients. There's also the option of using nanotechnology. This is data from several years ago from a group in Berlin, led by Dr. Johansson, showing the needle placement in the prostate, the injection of a magnetic nanofluid which could subsequently be heated. These are the isothermal lines showing very effective heating throughout the prostate and then rapid fall off into the rectum and surrounding normal tissues. So this is another approach that offers promise to patients in the future. We also have the opportunity to enhance outcomes through immunologic targeting. As my colleague well pointed out yesterday, the promise of combining hyperthermia with immunotherapy. If you look at the cancer immunology cycle, all 8 steps of the cycle are influenced by hyperthermia. So while the focus with radiation is on antigen spillage, getting that tumor-specific response, hyperthermia can also impact in many different ways, such as increasing blood flow, getting the activated T cells into the tumor microenvironment as well. Also, we are not limited in how often we can use hyperthermia, whereas if someone is responding to immunotherapy and getting drug every 2 or 3 weeks, we can't give radiation every 2 or 3 weeks, but we can give hyperthermia. And just to review, we have the thermal therapy, HMGB1, as we saw yesterday, along with heat shock protein 70, so the danger signal, and the heat shock protein, leading to a tumor-specific immune response that can go back into the tumor microenvironment. So it's nice to talk about that possibility, but what do we have in the literature? This goes back to the 1990s, where there was some intriguing findings from a study looking at transrectal hyperthermia. They looked at the CD4, CD8 ratios, natural killer cell activity before and after treatment, compared it to patients with BPH, so without cancer, as well as normal controls. And what they saw was a significant increase in the stimulation of cell-mediated immune parameters based on what they had available to them in the 1990s. And 2 patients with metastatic disease experienced a response in regards to their bone metastasis. So intriguing data to build on. Just putting hyperthermia aside for the moment, during my time at Dana-Farber, we looked at what happens with HSP70 levels over a course of routine radiation therapy for 2 months. About half the patients in this pilot study had hormonal therapy, and what you see is there was no difference with hormonal therapy, but every single patient had an increase, and this was about 3.5 times in HSP70, which was highly significant. When we look at markers of the pro-inflammatory immune response, interleukin-6, TNF-alpha, consistent increase, CD8 and NK cell activity also increased as well. We then went back and modeled this in the lab. We had very similar data for HSP70. I showed HSP27 because we couldn't differentiate HSP70 from a mouse of the tumor xenograft, whereas here, with HSP27, it's distinct from the mouse HSP25. And the takeaway point here is that this spike in heat shock protein release is tumor-specific. So it's a tumor-specific immune response. And we don't see that. This was 2 prostate cell lines, of course, a breast cell line where we did not see that. So it established that not only were we seeing an increase in HSP70, but it's linked to that tumor-specific response. What we also saw in our phase 2 study was in the majority of patients a significant increase in perfusion immediately after radiation, after hyperthermia as well. And getting back to the cancer immunity cycle, I talked about not just activating the T cells, but getting them where they need to go. And this is an important step that contributes to getting those activated T cells into the tumor microenvironment. And this is work from Dr. Rylander at Virginia, showing that you can also potentially model and predict the HSP70 response. Something may come in handy to us in the future as we move forward with this treatment strategy. Finally, I just want to touch upon biologic targeting, getting back to the question of DNA repair. The group in the Netherlands has done impressive work here, showing that we can mimic the BRCA2 mutation with hyperthermia. And so therefore, we can look at using hyperthermia to inhibit BRCA2, but also have the opportunity to expand that impact on inhibition DNA repair by using agents such as cisplatin to block other aspects of DNA repair, and also PARP inhibition as well. So we have the potential to combine all these therapies to make this most effective treatment for cancer patients. We have seen this in the laboratory with inhibition, with the combination approach as shown in red. Dr. Issels and his group in Munich have also looked at trabectedin, working through similar mechanisms in sarcoma patients to affect this added inhibition in combination with hyperthermia. At our own lab, we have looked at the combination in prostate cancer, and what you see here is the controls both in androgen replete and androgen depleted conditions. You get about 50% reduction, or maybe a little less, with either heat or PARP inhibitor alone, and about 50% more reduction with the combination. So we think this is a very promising approach that we are now actively moving into development of clinical trials. So in conclusion, I would argue that hyperthermia can be a benefit to many of our prostate cancer patients. But with that said, we have an opportunity to be smarter and thoughtful about how we apply hyperthermia in the future in a highly targeted way via the physical, immunologic, and biologic mechanisms that I shared with you today. So I appreciate your attention and just wish to acknowledge my colleagues in our hyperthermia suite, Dr. Roberts and Professor Stauffer. Thank you very much for your attention.
Очень интересное сообщение. Если можно, вопрос. Правильно ли я понял, что вы... Что?
Наушники надо.
Что?
Подождите, наушники.
Извините. Я тоже один.
Yes, I have it on.
Правильно ли я понял, что вот уровень белков типового шока является критерием ответа опухоли на гипертермию? Чем выше уровень белков типового шока, тем сильнее реакция или гибель опухолевых клеток, тем выше, да, от сеанса гипертермии.
Yes, in the clinic we, of course, haven't shown that directly, but you would presume, in terms of the immunologic mechanisms, that it could enhance the anti-tumor effects through the immune response. What I didn't show in the interest of time was some Western blot analysis from our phase 2 study, showing that even over the course of a 60-minute hyperthermia treatment, we could see an increase in HSD70, not unexpected, but a confirmation in our human patients.
Спасибо. Еще один вопрос. Ведь рак предстательной железы достаточно хорошо лечится и лучевым методом в комбинации с гормональными препаратами, даже при Т3, при Т4. И я думаю, что у вас, как и у нас, в случае рецидива опухоли, либо когда она не уходит, мы начинаем изучать почему. Вот какие, с вашей точки зрения, показания к использованию лучевой терапии и гипертонии в больных раком предстательной железы? Спасибо.
Yes. Well, you're absolutely right that there's a number of ways that we can kill a prostate. So, with modern techniques. But as you well pointed out, there are certain patients that we see with radio-persistent or recurrent disease. And that's a population that may very well benefit from hyperthermia in terms of its enhancement of perfusion, and maybe a hypoxic issue for some patients, also inhibiting that DNA damage from the radiation, to give an extra kick, so to speak, to the effects of radiation in these patients who are probably, for one reason or another, somewhat radio-resistant.
Dr. Hurwitz, could you please explain, is there any type of hyperthermia that added to prostate treatment that recognized by insurance companies paid for it?
Right. So in the U.S., with our deep regional device, like I showed you the patient with a recurrent disease, his insurance company paid for his treatment. We have, again, in those type of patients, we're never going to see a phase 3 study, but we have good data from a lead institution in Northwestern the U.S. to support it. So we have been successful in treating most of our, not just prostate, but other patients with advanced pelvic diseases getting reimbursement for them.
Is it common practice or just experimental way?
So we're doing this as common practice, keeping in mind, again, these are patients that are far from typical, and so we're not going to have, large clinical studies for them. But we do have literature to support the approach. For instance, our lead indication for deep regional treatment is recurrent rectal cancers, where patients have recurrence after radiation chemotherapy. They're painful, debilitating, and we have a paper in Cancer in 2005 from Juffermans and colleagues. Some of my Dutch colleagues were involved in that research, where they had 58 patients retrospectively, where 3/4 had pain relief with hyperthermia. Again, a situation where we're not going to ever have a phase 3 trial. It's not just patient numbers, but the heterogeneity of the presentations. But we can make a compelling point for the benefit of hyperthermia. And we also have Cochrane review data as well, supporting that enhanced response.
Thank you very much. Long question.
Sorry, еще один вопрос. Скажите, пожалуйста, вот вы использовали внутритканевую брахитерапию больных раком предстательной железы или и BSD аппарат тоже использовали?
Correct. The BSD machine is compatible with our nucleotron HDR system. So the same catheters that we're placing into the prostate for HDR can be left in place and then hooked up to the BSD system. And we put the heating antennas and the thermometry probes into the existing catheters.
Спасибо.
Thank you.